No escucho. ¿En qué estamos?
Okay.
Sí, pero no sé a cuándo se termina de pasar el caso. Hola.
Ah, where's the camera? Here?
Yes, the
Okay.
camera is there.
Okay.
So hello everybody,
Hello.
and thank you for all the audience. We're really sorry for the delay, but my team was not working well today. So we have the pleasure to have Amy Tiber from Robert Wood Johnson from New York.
Yeah.
New Jersey, really? It's better than New York.
Yeah.
Amy.
I work in New Jersey, live in New York. That's
work in
so
New Jersey,
either is okay.
live
Yeah.
in New York. She's
But-
part of the team of my good friend Dr. Kahale.
Mhm.
So tomorrow we will have also a live transmission with some cases of poem that we will do.
Mhm.
I don't remember how many cases we have tomorrow. ¿Cuántos casos hay mañana? So we have eight cases for tomorrow for poem. So we will have a live poem course
Mhm.
tomorrow, and it's for free in our YouTube channel.
Yeah.
So Amy,
Yeah.
this is how old have this patient? ¿Cuál es la edad del paciente? This is a 59 years old male with a history of chronic alcohol consumption, and he already have EUS endoscopic ultrasound previously because of suspicion of chronic pancreatitis. So we find some aspect of this chronic pancreatitis. So in our protocol, we follow these patients because the risk of development pancreatic cancer. So we are with you. What do you have? What can you explain to us
Yeah.
today with this case?
Yeah. First of all, I'm just so excited to be here. Thank you so much for having me, and I'm very excited to be using new equipment here as well.
Yeah, we have as an equipment. We have the Arieta 850. This is a quite new technology from Itachi Arieta Itachi company
Mhm.
that works with Pentax scope.
Yes.
So
And
this new technology have high resolution and harmonic tissue enhancement, so we can see much better the quality of image that we are looking during our EUS, as you can see here. So this is really fantastic image. So
Yeah, the images are really amazing, and we've been looking a little bit off camera already at this pancreas, and you can see that there's definitely some features here of chronic pancreatitis. So it's clear that he does in fact.
So can you explain,
have that
because there are a
diagnosis.
lot of people, a lot of physicians that doesn't perform EUS. Some of
Yes.
them are just starting to use to do EUS. So you can explain a little bit what do you are looking in this image. If you want, you can.
Yes. So I think oftentimes the first place to start is to find the pancreatic duct and trace that, and then you know that you're seeing all of the pancreatic body and tail that way, and that's usually where I begin. And what we're looking for when we are talking about chronic pancreatitis is there's a lot of different criteria. I tend to still use the Rosemont criteria the most, and you're looking for sort of major and minor criteria that will give you sort of a risk stratification of not only the diagnosis but also the degree of chronic pancreatitis. So let me just find here in this patient we're going to see some hyperechoic stranding, which means that there's some areas of the pancreas that instead of it sort of being a salt and pepper like appearance, there's some areas that seem very bright and linear, kind of linear densities on EUS, and that's.
So you are using a
Okay.
linear EUS scope. This is the
Yes.
the new scope. This is the J10 series. This is the first scopes in the whole Americas.
Yeah.
So we are glad that you are the first American woman and physician using this scope. That's
I
fantastic.
am really excited, and the images are
So,
so beautiful. I don't know how I'm ever
What do you
gonna
think
go
about the
back to
technology?
anything else.
What
Yeah.
do you think about the scope?
I think the scope is great. Honestly, it's a lot lighter, which is really nice, and the end is a lot blunter than the other EUS scopes.
And the tip also is smaller.
The
so
tip
it's
is smaller,
fantastic.
yeah. And the camera's less on the side, so you have a little better view endoscopically as well, which makes it easier to pass. But most importantly, I think the EUS images are really just fantastic, and it really allows you to see in beautiful detail, look for all the features that we look for when we're trying to diagnose.
So what we are
pathology in the
looking now?
pancreas.
What part of the pancreas you are now?
So this is here. This right now. You can see this black structure kind of in the middle of the screen is the duct, and that's it going down to the neck right there. And I believe if we measure this, it's going to measure to be a little bit dilated.
And it's irregular also.
Yes, exactly. The other things we look for, the wall doesn't look particularly hyperechoic or bright. That would be one criteria to look for. So he doesn't have that criteria in this case.
So Amy was talking about this part. If you see, there is a little bit of this is the main pancreatic duct, and this main pancreatic duct is very regular, as you can see here.
Yeah.
It's not a normal. This is not the normal duct, because normally, how is the duct?
It's smooth and straight, and it doesn't really look sort of jagged like this. Yeah.
That's it.
Yeah.
So you are going to the neck.
So this is the neck here, and then if you sort of rotate a little bit and follow the duct, you end up. So we just zoomed out just a little bit, but here you can see the duct. Sometimes a little bit harder to see, but if I rotate just this way, now we're looking kind of at the body of the pancreas right here.
So you are in the body of the pancreas here.
Yeah.
I will show you for physicians that
Here
doesn't perform EUS very well. So this is the pancreas, and this is the body of the pancreas. That's it. So what do you think now? What are you looking for now?
Again, here it doesn't look so homogeneous. It looks a little bit irregular. Again, you can see these kind of these like bright white streaks here. These we call this stranding.
This is a minor criteria for Rossmann. That's it.
Exactly, and I don't see this. The other thing we look for is the lobularity, which almost looks like honeycombing of the mucosa. I don't see a ton of that here, although we're going to go to the head of the pancreas in a little bit, and we did see some of it there.
Totally agree.
Yeah.
So for first evaluation of this area, okay? So for Amy and for me also, so we see a pancreas that have some hyperechoic linear areas and some irregular areas.
Yes.
But there is I don't see worrisome futures regarding like a big chronic pancreatitis or something like that.
No.
At least in the body of the pancreas.
Yeah.
We saw over the neck just a small, a little bit irregular main pancreatic duct with a small dilation. So we have some doubts regarding the chronic pancreatitis of these patients, and we need to see more other characteristics, at least on the EUS first. No?
Exactly. We're not seeing calcifications. That would be very suspicious. We're not seeing sort of slam dunk very severe featers. So do you want to use some of the?
No, we move to the head. Okay. We will see completely in the B mode, and then we will talk about a little bit about new technologies and what can we use also when we have this kind of patients also. Where this is
so here now I've gone into the duodenal bulb, and you can see my portal vein here.
The portal vein is here.
Yeah.
So again, it's here.
Yeah. And I'm just going to sort of follow it around till I come to the head of the pancreas. Let me try to find you a nice view here. Okay, so here we're seeing, this is the bile duct here, I believe.
So I will show you. This is the bile duct.
Yeah.
Okay.
Also a little bit
thick, huh?
Yeah.
to my opinion, is a little bit thick.
Agree. A little bit dilated, and the wall is a little bit
Yes.
thick.
So wait.
But we will measure just to be.
I will measure. I will try to come back a little bit.
Mhm.
Okay, so here we have a better image,
Mhm.
and now we will measure. So this patient doesn't have jaundice, okay, but it's a little bit thick. I
Mhm.
totally agree with you,
Mhm.
okay, and I think it's also dilated.
Yeah.
Wait a minute.
So that was the wall we were just measuring, and then
And now
everything
we'll-
on fluid on EUS appears black or anechoic. So vessels and ducts are all going to appear black, and so we know because we do a lot of EUS that this is the bile duct, but we could, prove it to ourselves by using our flow to show that there's actually
So
no
you-
flow in this
we
area. So
will-
that
we
is in
will
fact the
use
duct.
E-flow
Yeah.
is much better.
Yeah. And so
Okay.
you can see there's no flow there, so that if you
That's
don't
it.
believe us, you can believe the technology. This is definitely the duct.
Okay, perfect.
Okay. All right. So I'm just going to try to get a little bit picture. So you can see below the duct here, and here you can actually see even more so how dilated the wall of that duct is. And then what usually happens is the bile duct and the pancreatic duct kind of stack on top of each other in the head of the pancreas here.
So what do we have here? So this is the head of the pancreas,
Mhm.
okay, as you can see here. So we see not just the main pancreatic duct, we start to see some other ducts
Mhm.
that probably are secondary ducts,
Yeah.
to my opinion. I don't know, what
Yeah.
do you think?
No, I agree. I agree.
And there are some hypoechoic areas with
Yeah.
hyperechoic areas also.
Yeah, this part of the pancreas certainly looks much more concerning and abnormal, I think, than the body and tail. Here you can see here this whole area down here just looks very abnormal. There's more of these densities. I think we're starting to maybe see a little bit of lobularity here.
You
What do
can
you
see,
think? Yeah.
I don't know if this is a start, some calcification areas, but
yeah.
we start to see this is completely irregular areas. We have hypoechoic areas.
Yeah.
We have these hyperechoic, linear spots here,
Mhm.
and we have some dilation of the secondary ducts here.
Yeah.
So probably this area, this head of the pancreas is more concerning, regarding the disease that this patient probably have.
Yes.
Okay, so
And you can see how sometimes in chronic pancreatitis, it can actually be very hard to find small lesions or masses
yes, and
because the calcifications or the hyperechoic areas can make it very difficult to see below them and just make it hard to find tiny little lesions. Yeah.
totally, and the situation is that we need to follow up these patients more, more and more, because these patients, at least 20 to 30% of these patients can develop a pancreatic cancer in the next years.
Yes.
So that is the main concern of this kind of patient. So this is a follow-up of this patient, and it's very important to have the follow-up. I have some patients that in the past I followed during years, and 3 or 5 years of follow-up, the patients develop a pancreatic cancer,
Right.
and it's really a disaster when you are not, looking for this situation, this concern during the follow-up.
Yeah.
So the other situation is that sometimes we can have some doubts. For example, this patient have the head of the pancreas that is very, very have a more clear disease regarding chronic pancreatitis. These have more Rossmann criteria, minor and majors.
Yep.
Okay, so you can see here the main pancreatic duct here.
Yeah.
I think
And
it's
this is definitely dilated here. Yeah.
and here is 42.
Yeah.
So it's definitely very dilated. This is clear,
It's very abnormal.
very abnormal in this area. So, but sometimes we can find some patients that already just have some spots, hyperechoic or some minors criteria, that probably cannot give you a good diagnosis of chronic pancreatitis. So
Yes.
in these cases, we can apply also new kind of technology like elastography. That this is will measure the tissue. If the tissue is the elasticity of the tissue, if this is hard or this is soft tissue.
Yeah.
So this could help us. This is other kind of technology that we can use also, and we can apply, because when we apply this kind of technology also, we can have more details regarding the diagnosis that we can offer to our patients.
Yeah.
So we will use
Yeah.
in this case elastography.
Yeah. It's also great because it's not at all subjective. I mean, here you have clearly computer generated objective data. You know, I think it's hard to, when you're talking about these criteria, some people may, different experts may see different things, even those with a lot of experience doing EUS. And it's nice to have some objective data to be able to add to our diagnostic
So
armamentarium.
now this is we can apply, you know, this is we can apply two kind of measure with elastography. We can be objective and subjective. Subjective is more to see the colors, okay, and the colors is just a representation of the gray scale. This is not true colors, okay. It's just the software that give us these colors, but this is based on the gray scale that we have more than 255 gray scale. And that is very important because there are other software nowadays that have also elastography, but probably the gray scale is not higher, and when it's not so high, your sensibility and specificity will go down.
Right.
So we can apply also just the criteria of the colors. You know, this is subjective, as you already mentioned, and for me could be normal, and for other physicians could be abnormal.
Right.
So it's very difficult, but we can also now use other kind of measures. This is the head of the pancreas, so I will use one of these objective measures is using the strain radio. And the strain radio was described at first by a good friend of mine from Spain. Is Dr. I don't remember. It's Julio Iglesias Garcia. Yes. So Julio already described this, and we are measuring this. So the strain radio was already used in other kind of ultrasound, normally in for breast or other kind of lesions, and the idea is to compare the measures. It's a qualitative evaluation from the areas, the region of interest. In this case, A, that is our head of the pancreas, with a smooth tissue to the soft tissue, that in this case is mucosa layer. I always use mucosa layer because I receive a very good teaching from my good friend Mark Giovannini, and as he always say, mucosa layer is very important because mucosa layer is always the same. It will be always soft. But if you measure with the same pancreas tissue,
it's not a good comparison.
It's not a good comparison. So in this case, for example, we have
it's like having a control group.
That's it.
Yeah.
We have a difference between A and B that the number is 459, as you can see here. So down in the panel, you see B versus A, and it's 4.59. So normally is until 2 to describe abnormal tissue. So in this case, the strain radio is saying to us that probably it's a chronic inflammation here. This tissue is not normal.
That our eyes are correct, and that this is in fact very abnormal.
We have the endoscopic ultrasound criteria. That is the Roseman criteria. But also we have new technologies that could be applied. Also, I also really like to use the strain histogram, because the strain histogram is a measure of the whole histogram. You can see here in your monitors. I will explain to you. This is the scale of the gray scale, 255. Okay, so this grayscale is our parameters, and this is giving us the colors, and the red color means that it's soft, and the green color means that it's not soft, okay, or it's inflammatory tissue, and the blue is so hard tissue.
Right.
So in this area we have a combination of color, more gray and blue than red. So in this case, the mean strain histogram is 97. What means that? Normally tissue in our series, in our center, is more than 100 and 120 to consider normal tissue.
Normal pancreas.
Normal pancreas using a strain histogram. But when we have less than 100, between 50 and 100, it means that there is an inflammatory disease. And this would help us just also to confirm what we are looking during our procedures.
And this is nice because it averages a whole area of the pancreas, not just a small circle like the last. So there's a less sampling error because you're really seeing the whole EUS image here.
Yes. So this is a technology that is also available, and that maybe we are not using so much in other countries, but this is very interesting as a complementary tool that I think is very important to have this kind of complementary tools always in when we are using EUS, endoscopic ultrasound.
Yes.
I don't know if we can go back to the
body tail.
To the body and the tail, just to perform some measures here. We already measured before start this evaluation, and the results continues to be the same. So this is very good because it seems that really the strain, the ratio, and the elastography help us a lot. So now we are in the body of the pancreas. I want that you fix it a little bit more. That's good.
Yeah. Okay.
So I will do an elastography. Wait a minute.
Yeah.
So it's very important to have. Okay.
Okay. Here we go.
So now we have mucosa layer. Okay. We have the main the body of the pancreas inside, and we don't have vessels or other things. So it is important to use the frame average because this is a technology that permits to eliminate any kind of artifacts that we can have when we are using this technology. And we will use also the strain radio to try to measure region of interest, a ROI, compared with the mucosa layer. In this case I will use the red, the soft tissue. Also always try to use the soft tissue. This is 2.70. As we can see, it seems to be normal, not very affected as the other part, but we will use the strain histogram also. Wait. And you see the mean continues to be 91.
Right.
So a strain histogram is evaluating the whole pancreatic, pancreatic area, as you already mentioned it, and could be more interested as a data. We are working now to see the results of retrospective evaluation of all the patients that we already have here with pancreatic masses and chronic pancreatitis. So probably could be the future, and new kind of applications could be developed, moreover in liver, for example, disease with this. This new machine have a difference from the other machine, the 870, that we will perform some cases right now. The next case we perform with another technology. But the difference here is that the strain histogram is automatic. So you don't need to measure. You will see the difference between the machines, and probably this could be more interesting for the future. So we need new kind of studies to to see this.
Yeah, but it's exciting. It's really exciting technology, I think, and especially with chronic pancreatitis and screening for pancreatic cancer, there's still a lot of room for improvement there, and this I think is really, really exciting to help us in those patients.
So perfect, Amy. So what is the follow-up for these patients?
So, I think we've definitely confirmed both with our own EUS criteria as well as with this new technology that he certainly does carry a diagnosis of chronic pancreatitis. And we know that his risk of developing higher than someone without that diagnosis. I don't see any lesions right now that look like there's a mass or concerning for cancer at this point, but I think certainly he's going to need regular follow-up, both with the clinical history as well as maybe repeat ultrasounds using this technology.
Yeah. So and there is a big question always between different countries, and it's when do you apply FNA or FNB in this kind of patients?
Yeah. I think right now there's really no guidelines to help us there, and so it's really is physician by physician and institution by institution. I generally, if there's any change in clinical symptoms, I almost always will.
It means weight loss
or
jaundice
or pain that wasn't worsening, or any kind of change in their sort of overall status quo. I have a very low threshold to go in and sample.
Yes, in my practice I use the same,
Mm-hmm.
and also clinically I follow up these patients each 2 or 3 months. It will depend of the characteristic of what I am looking. For example, this body of the pancreas seems not so bad, with the difference of the health of this pancreas that needs to have more attention, and I see exactly the same. So the clinical aspect of the patient first, and second, I always measure the serum markers, for cancer,
Right.
CAA and CA99,
Yeah.
just following. And if I see any kind of change, I will perform a US, as already say my good friend Kenneth V. Muller. I am more sure of my US than other kind of CT scan or MRI.
Absolutely.
It will depend. This is operator dependent, and I always perform on US if this patient have any kind of change during the follow-up, the clinical follow-up.
Yep.
So we will finish with the first case. We will perform a small pause, stop, a small
Break?
break,
Yeah.
a small break to change the room. We will change the room. So we are just 2 operators, and we will perform the next case in just 2 or 3 minutes.
Okay.
So continues with us during the live transmission today in our YouTube channel. So we finish with this case, and
All
we
right.
close this case. We will pass for the next case. Okay?
See you in a few minutes.
So see you in a few minutes.
Yeah. Okay.
So hello,
Yeah. Oh, okay.
we're live now. This is the next case.
Oh.
¿Cuántos años tiene este
I think-
paciente?
I think. I'm trying to put so we're both on.
No, it's okay.
Okay.
Don't move the
Okay.
camera.
Okay. Okay.
So
Is that
come
good?
more here.
This way?
Okay, fantastic.
Okay. Okay. Good.
So we are with Amy working here.
All right. Hi, everybody. Welcome back.
So this patient have jaundice and weight loss, weight loss, with ELR lesion that was confirmed to have a cholangiocarcinoma. So this patient was sent just to have an endoscopic ultrasound to evaluate if this this patient can be going to resection or not, to a local staging. So first, what I see here from the mediastino, I am using a radial now, EUS scope.
Mhm.
So you can see here, I try to find some lymph nodes, but what I see is pleural effusion here.
Mhm.
You see here?
Yep.
Okay, there are some pleural effusion. You see here also. This is not normal. Here,
Right.
just back from the aorta. And there was another area that I see much easier to. Here, you see. This is
Oh yeah.
a pleural effusion, very clear,
Mhm.
and this is a pulmonary tissue. Okay, collapsed because of water. So second, I am now on the level of the cardia. So we are working with a radial scope again, and with but this is a other kind of machine. This is the Rietan 70. Okay,
Mhm.
so you can see here, as already Amy said, there's a very delayed biliary tract.
Right.
You see, so it's
It's almost jumping out the screen at you that this is really, really dilated. All of the
really
ducts here
dilated,
in
yes.
in the left lobe. Yeah. Yeah. You really shouldn't even be able to see the bile ducts in the liver very well in here. They're
Yes.
very prominent.
So we also try. Look
Mhm.
here, really dilated.
Yeah.
So, and it's not drained
No.
because I don't see air
Yeah.
in the biliary tract. So this is why the patient still have jaundice.
Yes.
The other situation is that this patient have ascites also,
Right.
and probably this is
That's probably the worst prognostic
yes.
sign that we've seen on ultrasound so far.
Yes,
Yeah.
yes, totally agree.
Mm. Yeah.
So probably there is carcinomatosis in this patient.
Yeah.
I am looking here the pancreatic the pancreas. Huh?
Now we're using flow here.
Yes. So you can see the splenic artery,
Mhm.
and you can see the splenic vein. I am really concerned.
Again, the image quality with this machine is just really, really superior and impressive.
Yeah, it's impressive. Yeah.
Mm.
So this is my aorta.
Mm-hmm.
Rotate.
You can see it.
And I try to find my pancreas body. The body's here. just down at 6 hours. Okay.
Yeah. You can try to
Yes.
point
Wait.
through.
Here. I will try to see button display and. Okay. So Amy, we will show us.
Yeah. Yeah.
So here you have. Yes.
Yeah.
So that's the main pancreatic duct here.
Yeah, right there.
It's
yeah.
not dilated.
No.
This is an indirect sign of there is not any mass in the head of the pancreas.
Right.
So I see the body of the pancreas also normal. That is all these areas you can see here.
Yeah.
And
So
it's
that
very
goes along with a hilar lesion more than a distal
yes.
lesion.
So I try to find some lymph nodes that I don't see here in this area. Even in the celiac trunk. The celiac trunk is here.
Mm-hmm.
But we have ascites.
Yeah, it's quite a bit. Yeah.
So we see the gallbladder.
Really
Really,
sludge.
yes,
Yeah.
a lot of sludge, but
Yeah.
also
So
with
all
the,
that gray stuff on the
and the wall is a little bit thickness.
it is thick. Yeah.
So this patient
Yeah. So let me see
is
if I can point it for you. So right
this is
here,
a
this is all the sort
the
of
sludge.
thick sludge in the lumen, and this whole thing is the gallbladder. This big circle.
Yeah.
Yeah.
And we have a
It
lot
does look
of
like thick,
ascites.
although it's right. There's ascites around it, so that
Yes,
may be partially contributing.
Yes, totally agree.
Mm-hmm. Yeah. So now
So
we've
the-
moved into the duodenum.
Perfect.
Mm-hmm.
And
And
we are
again-
trying again to see. To see the. Trying to find the head of the pancreas first,
Mm-hmm.
and also the bile duct, the common bile duct.
Mm-hmm.
So I will pass more.
Okay. Aha.
And I will come back just to find my common bile duct.
Mm-hmm.
That is the gastroduodenal artery here.
Yeah. Yeah.
We can confirm here also. You see?
Mm-hmm. Mm-hmm. Yeah. Okay.
So
So you're shortening
yes,
the scope here, right?
I am shortening my scope just to find.
Right. So oftentimes that's how you can best see the bile duct and the pancreatic duct close to the ampulla as you
That's it.
push into the second portion of the duodenum and then reduce and shorten your scope to find
So here is my bile duct.
so it doesn't look too dilated down here
No, because the problem is
above it. Yeah.
above it.
Yeah.
Yes.
So again, we're just confirming that this is probably all a hilar process.
So let's go. Oh, not so fast.
Mm-hmm. You can see more biliary dilation in the liver. Yeah.
So now we have here is the bile duct. You see here?
Mm-hmm.
So we need to follow up this area. It's a little bit. There was a stand or not? I don't believe. Huh? Podemos hacer rayos X rapidito. Probably it's there. Yeah, it's there.
It must be a stent, not.
Yeah, this is a stand.
Yeah,
You see here?
yeah. But I think it's not in the intrahepatic enough, and that's
Oh, yeah.
why.
This is the stand.
Yeah.
So this will help us even to follow. Just
A lot of EUS is kind of identifying structures and following them and tracing them by manipulating the scope. And I always tell my fellows when they're learning, it's about little movements, using torque of the scope, even sometimes rotating your body in different ways in order to to follow these structures.
Yes, that's the idea. The problem here is that all is becomes far because the ascites,
Right.
and we cannot arrive to see very well. I just arrived to see here, and I cannot see very well the common bile duct.
Yeah, there's a lot of ascites here.
A lot of ascites, yes.
Yeah.
Maybe if we see from this part, probably we can arrive to see better. Sometimes we can arrive to see from the stomach.
Right, going towards the antrum of the stomach, you can sometimes see the head of the pancreas. Certainly you can see the gallbladder sometimes from here.
Very difficult case
Yeah.
to see by US, but at least we know that this patient is not more a resectable patient.
Right.
Um,
Right. We've achieved our objective mainly with the EUS, which was to do the staging. And
Yes,
I think the ascites answers that question for us.
yes.
Unfortunately.
I think it's very important also to have some evaluation of the cytology of these ascites.
Yeah.
So I will change the tube. I will change with my scope. I will use a linear scope to try to see better my main bile duct.
And also to maybe sample the
Yes. Try to see much better. Yeah. Very
hard
dif-
to see.
yeah, very hard to see.
Yeah.
Normally it's easier to evaluate, but the problem here is the amount of ascites. So I will use fine needle aspiration of these ascites, and we will try also of cameras to do the ERCP or cholangioscopy just to see what happened inside and try to treat this patient, to drain this patient is very important.
I think longer stent
Yes.
to the intrahepatic.
Oh yes, certainly.
Yeah. So we're looking at a fluoro image, and the stent actually only goes up sort of the common hepatic. It looks
Yeah.
like, so it's probably not crossing the obstruction.
Quiero un lineal, por favor. Sometimes we can see here, but with the linear probably I will see better the ileum. Look, wow, my God,
So dilated.
so dilated,
Yeah.
totally
The
dilated.
whole liver.
Yeah, it's a whole
I
liver.
don't see any liver lesions, though.
No,
Although I think liver lesions can sometimes be very hard to appreciate
yes,
on the US. Although with this improved image quality, it might be easier to see.
yeah. So in your hospital, you do cholangioscopy for this kind of cases?
I do, especially we do a lot of cholangioscopy in terms of mapping where the cholangiocarcinoma
Yeah.
is for the surgeon, especially if it's a potentially resectable patient. So we'll do cholangioscopy, try to go above the tumor on both intrahepatic ducts and kind of map the degree of involvement pre-surgery. And also we do a lot for diagnostic purposes. Sometimes brushing is not adequate, and
Yeah.
cholangioscopy-directed biopsies can really be
And
helpful.
yeah, we need
And
to remember.
visualization as
Yeah, visualization is much better than biopsy. It's incredible.
Yeah. Also, the other thing I use it for is if I can't get into a specific intrahepatic segment, sometimes I'll use cholangioscopy to help me identify exactly where the opening is, so that I can direct my wire there, so that I make sure that
Yeah.
I stent all as many radicals as possible. What about you?
Yeah, myself too.
Yeah.
We use a lot of cholangioscopy, not just for diagnosis, also for the extension of the lesion, and also for have better tissue.
Yep.
Quiero una 19, puede ser normal. So I will use a 19 gauge needle.
So radioscopes don't allow for FNA or FNB, so that's
Yes,
the main
that's
reason why we're switching here so that we can do some sampling.
so again.
And you can see the anatomy is a little bit different when viewed with a linear versus with a radial. But same findings are
You see
clearly
here.
evident here. The whole
This
liver
is this is a collapsed pulmonary tissue
yeah.
because
As
of
we saw before, yeah.
I don't see, and this is the pulmonary aortopulmonary window. We don't see nothing, and this is
Here's our liver full of dilated ducts.
fully dilated. Yes.
Really
So if we needed to do a drainage, for example, by EUS, this is the window.
Yes, this would be a great case for.
Yes, if we cannot arrive to drain by ERCP.
Yeah, and that was a great window because there was no ascites in our way. A small amount of liver between the lumen and the bile duct, so really ideal.
Yeah.
Okay.
You can see very nice here.
So again, normally bile ducts intrahepatic are 1-2 millimeters on the EUS, if that even.
Yeah.
These are going to be much more than that.
Yeah.
Yeah, so this is almost a centimeter.
It's a very nice area where we can work. I am trying to see so this is a portal vein here, and normally we can have behind the bile duct, the common bile duct.
Right. It's hiding today.
Yes. The idea is to see from this area. Here. So I'm trying to follow my bile duct. The idea is to see my ilar region. Sometimes difficult, sometimes not. Just to see exactly what happened there by EUS. Yeah, let's go to see.
So we don't generally sample hilar lesions through FNA or FNB though.
Now,
because of the risk of seeding. So we like to look if we can see, but we wouldn't. I mean, in this patient, he's likely unresectable, but certainly that's
yeah.
there's a concern for seeding in patients that are potentially resectable if they're sampled. Here is
Yes.
diabetes.
Okay, dame la aguja. So I will take some sample from the liquid, so from the sites. The idea is to send to evaluate also. But this is very dilated, very tract. So
fluid is going to look anechoic here. So all this this area right here, this is all the ascites here, and you can see the liver kind of floating right in it.
yes,
And interestingly, if you flow the ascites, it's going to look like it's like there's flow there.
yeah,
That's just because it's moving. It's moving liquid, and it's not actually.
because it's a true vessel.
It's not a. It's not a. Yeah. It's not a vessel.
So in this case, I will use a 19 gauge needle, a standard needle. I'm using an spec needle.
And that's because you can get the most amount of fluid quickly with the larger gauge.
Yes, this
And
is
you
very
have a
good
big
position.
target here. Yeah.
I'm inside.
So,
No, not inside.
see the wall is a little bit thick here. Want me to hold the.
Maybe. Right here. I'm inside.
That's it. Yep.
So it's very important to see the tip of the needle.
Yeah.
It's just here.
See it.
Difficult to see. Huh?
Yeah, a little bit. There it is.
Ah,
there it
there
is.
is.
Right there. Yeah.
And I have the fluid here.
Yeah. So you can see sometimes, depending on your position, as you push the needle, you can actually push the tissue away instead of going through. And it's just about finding the right angle. And what I tell when I'm training fellows how to do sampling, I tell them, that it's not the time to be sort of gentle and gently push out the needle. You really have to do a sharp jab, but very controlled. It's counterintuitive. You want to be gentle initially and push the needle out slowly, but a lot of times if you have a thick wall, like in this case, you really need to do quite a bit of force
Yes.
in order to get through.
Pásame de
And not
nuevo.
tap the tissue away. Yeah. Yeah. Here now you can very clearly see the tip of our needle right there.
Yeah.
So you're going to send this for cytology.
Yes. I think it's very important.
Yeah, I mean, if you flow this, it looks like it's a vessel because it will flow similar to a vessel, but it's not. And if you're ever concerned and not sure, you can actually use check the pulsatileness and prove that it's certainly not a vessel. Yeah. But it is disconcerting sometimes when you're beginning and you put the flow there. It can look nerve-wracking.
So okay, I think.
A little bit dark.
Huh?
It's a little dark.
A little. Yeah.
Yeah.
I think we finish with this case. We will change the room and change the case. So we will perform a break. And we will come back with you with the next case.
a few minutes.
See you in a few minutes. Come on. We need to evaluate a little bit better,
Yeah.
I think,
Yeah.
just to see, because this patient have chronic diarrhea. So when we
Yeah.
have a patient with chronic diarrhea, we need to think in many things. First, that probably if this patient have something in the head of the pancreas, probably it's a disease of the pancreas. And in this case, I think one of the part of the differential diagnosis from this cystic mass could be an IPMN
Yes.
that could give you some kind of chronic diarrhea when it's associated to chronic pancreatitis.
Yeah. I agree, although the pancreas didn't look, it looked pretty healthy, at least in the body tail. So, but we can use our technology to,
Oh, for
Evaluate.
sure, to evaluate.
for sure. So it looks like it has multiple compartments here.
So one thing that I some concerns is in this area here. So you can see here, this can be mucus.
It could, but
Also.
it could also be a solid area there.
Yeah, probably, but
Although it seems
it's
to float a little
it
bit.
seems
Yeah.
to be flowed. You see here?
It's a little mobile, so that goes more for mucus.
So probably, we don't know. So the idea is to evaluate very well this cystic lesion and regarding this,
Yeah.
we can have some.
I'm just trying to look at it from as many angles as possible.
So regarding the characteristic of endoscopic ultrasound,
Yeah.
in this case, Amy,
Yeah.
and with the clinical aspect of the patients, of this patient, what do you think? Do you think that this patient have a benign cystic lesion? What kind of cystic lesion this patient have?
I think
It's difficult, huh?
it's so hard to say. You know,
That's the same that we said. We already said during this DDW we sent work with 140 cystic lesions, and really the accuracy of EUS for this lesion or for overall for macrocystic lesion is very, very low.
yeah.
Even that during the last 30 years
Yeah.
had a very important role increasing the diagnosis of cystic lesion because of FNA, but with a lot of limitations also.
Yeah.
That's why we believe that new technologies is always useful
Yes, absolutely.
to evaluate this kind of lesion.
Right. I mean, just by looking, you know, the differential remains very wide. We're not seeing an obvious mass, so it's, you know, it's hard to say is it's even benign or malignant at this point. There's no obvious clues that are
Where is the
sending
main
us
pancreatic duct?
one way. The main pancreatic duct's hard to see. I think it's mixed in here somewhere. I know that the duct is not dilated more upstream in the body and tail, which is reassuring, but again, is not 100% indicative of a benign versus a malignant lesion. And then, you know, it's well defined. It has multiple septations.
Can we see the ulcinate process? Can you
Yeah.
pass a little bit more?
Yeah.
Just
So
to see
I'll
very
go in a
well.
little bit.
Maybe we can have some kind of information also. We can try to see the papilla also, because if we are looking at or trying to think about an IPMN, sometimes we can see mucus from the papilla.
Yes.
So the idea is to evaluate the whole components of this patient and of this lesion.
Yeah. Or we've sometimes, very rarely, but sometimes you can see the fish mouth.
Yeah, I know.
Ampulla.
It's
Although I
less
have
than 30%.
yeah,
But the lesion is still there, so
yeah. I know. I'm just trying to. So the way her anatomy is, it's a little bit tricky to reduce here. Okay. There we go. Oops, sorry.
Look. Look, wait. Here.
Yeah.
Don't move.
So I'm trying to find the papilla
yes.
here.
So this is the main pancreatic duct, huh?
Yeah.
From the uncinate process.
So here.
And it's irregular.
It's undilated.
Yeah.
Yeah.
So this is very important.
Yeah.
Because
Yeah.
if we are thinking about an IPMN, probably is
It's involving the main duct, at least in the head
because
here.
in the head of the pancreas
Yeah.
is
I'm trying to
impossible
get a little
see.
bit better image for you guys. Here we go. Okay. So let's see if we can see the papilla here now. I don't know if they only see the EUS view, not the
Just perform aspiration, complete aspiration,
yeah.
and push a little bit the scope.
Yeah, so here's the ampulla here. We can try to go long and see if we see
it's
it a
not
little
possible,
more. Yeah. Yeah.
Maybe if we...
Here we go, a little bit. Yeah. But yeah, it's tricky.
Okay, aspiration now. Just aspiration.
Yeah.
Just aspiration.
Yeah. I know, I was just trying to get an endoscopic image of
Okay.
it. But there we go.
There's nothing.
Yeah. So there we don't see the fish mouth.
No.
No. Okay. So let me collapse here.
So
So we're still seeing it.
And the uncinate process, huh?
Yeah. So it actually looks even bigger from this view.
Wow.
Yeah. So
now, with all these details,
So
what do you think?
So I'm a little bit more suspicious that this is an IPMN now involving the main part of the duct in the head.
Or do you think that this is serous cystoadenoma?
It's again, it could be, but those are usually smaller compartments. But certainly it's not ruled out. So
what is the next step, my friend?
So I think we have a couple tools that we can use. I mean, the one of the most well studied, I guess, is actually just to sample the fluid, send it for CEA and amylase levels. That can help us distinguish. But I think in this case, actually using confocal endomicroscopy might be very helpful, because if we do see features consistent with a serous cystoadenoma, then that's pretty much pathognomonic that this is a benign lesion. And sometimes we're able to see features consistent with an IPMN using confocal as well, which would be very helpful in the diagnosis, because again, the differential here is still pretty wide. What do you think?
Yes. Always in my practice, you see here, this is a very interesting area.
Yeah.
So here is very blurry area, and we don't know if this is part of the pancreatic tissue, or we don't know if this is
mucus or a mass.
Or mucus. So it's very difficult. It's really difficult. This is a very difficult case. It's not an easier case.
No.
But
and this looks a little less mobile, this solid area. So I'm actually a little more worried about this area than the last area we saw. What do you think?
Yes.
Yeah.
So we can use contrast also?
Yes.
Why
yes,
not?
we don't have that in the US, but I know you guys have it here.
Podemos usar contraste, por favor.
It looks it's great.
Vamos a usar la mitad de la ampolla, por favor. So it's very important to see on this area. Okay, wait a minute.
Yeah. Interesting. I think this is much bigger than the 2.7 centimeters that was that looked on imaging. So again, the importance of doing an EUS. Okay.
Momento, todavía no.
So unfortunately, we don't have contrast imaging in the U.S., but I've seen it a few times, and it can be very helpful in differentiating lesions. So I believe we just gave the contrast.
Wait.
Okay.
Okay. Ok, ¿ya estás lista? Momento.
Okay.
Ok, listo, dale.
Okay. So we have our images side by side here.
So the idea is to see here.
So I'm trying to keep the sort of the concerning area that we saw in view.
Yes.
So you can see it in the middle of the screen there.
So contrast is arriving.
So we see it getting bright.
So this is mucus. You can see
Yeah.
we are not having hypercaptation.
Right. So I mean the contrast is not being taken up at all by that area. So that's a reassuring.
Yes.
Here you can see. So here's the area.
Yes. Perfect.
Okay.
Store.
So there you can see very clearly.
Yes. So one of the interesting point of this new technology from Pentax Hitachi is that we can let me see, where is the video? We can do a CHA evaluation, okay, with the region of interest that will be this one, okay, and we can see the curve of captation of this area. So it's clear that this area, but this is the septum, have a hypercaptation, as you can see here, to 66, and probably with the time, you see here, this is just the few seconds at the beginning, and this is a bigger hypercaptation. The high hypercaptation area was this one. So we can see also the color map gradation of the area. So we can see the area, this area that is the main, this is the region of interest. There is not a captation.
Yeah.
really captation.
Right.
So I think it's the evaluation is not now just subjective; it's more objective. So it's very nice technology
Yes.
that probably in the future we can differentiate between neuroendocrine tumors versus cystodenom, serous cystodenom that appears like a mass,
Yeah.
or inflammatory
Yeah.
lesions.
Yeah. It's very clear this is not a mass. So
Okay, so we will close this.
okay.
We will exit from here, and we will go to the B mode. Okay.
Okay, so we're back to the EUS image.
So now we will use a fine needle biopsy preloaded with confocal to try to see the cystic lesions and the characteristic of this lesion.
Okay. And
¿Me
then
puedes poner la imagen del confocal, por favor? So we will use a 19 gauge needle.
yeah. So that is
So-
one limitation of the confocal technology, that it requires a 19 gauge needle, which in this case the lesion is large, so it should be okay.
It's okay. I think it's
Yeah,
okay.
Yeah.
One of the most interesting points in this case is that we are using a J10 series, so this is a 4.0 millimeters channel diameter. So it's easier to pass the needles in some angulations, so
Yeah.
giving
Yeah.
an easier way to work.
Which is great because this is the uncinate, so it's notoriously a little bit more of a difficult place to sample. Yeah, that's great. And I'm just gonna flow here. Oh, not helpful.
E-flow?
So just make sure there's no vessels in our way, which there's
No.
not.
That is very important always. Try to see if there is any vessel.
So it looks like no matter where I go here,
Yeah.
we're okay.
So, we will discuss a little bit regarding this mass and the evolution of this patient, because family is very worried about this his situation.
Yeah.
So I think the main pancreatic duct is here. It's probably this part. You
Yes.
see?
Yeah. Very
And-
hard to tell, but it looks like it could.
Yeah, it
Could
could
be,
be.
but-
So if this is IPMN, probably this is type 1, type 2.
Yeah.
This is mixed.
mixed, yeah.
Mixed.
Yeah, with that dilation in of the duct here in the head, it's almost certainly involved. Yeah.
And if we confirm the IPMN diagnosis, está calentándose recién el láser. So at that moment, I think that surgical resection will be the
Yeah, I
main
think.
indication. So that's why it's very important to
Yeah.
differentiate if this patient have an IPMN or a serous cystoadenum.
Right.
And sometimes it's
Excellent.
difficult. Huh?
Yeah.
I am not so
Yeah.
good doing EUS alone, so I always use complementary.
Yeah. Well, I think it's as we were saying before, it's really nice to have objective plus subjective data as well. Although confocal, I guess, is still a little bit objective.
Yes.
But
Dile a Bolaños que me ponga la imagen del confocal aquí.
But we picked cases today. These are all cases where, there's a lot of room for improvement in terms of diagnostic accuracy and sensitivity. Pancreatic cancer in the setting of chronic pancreatitis and pancreatic cystic lesions. We're still dependent on new tools and technology to help us in these cases.
Yeah, I think,
so-
at least on our study, sí, puedes abrirla. We evaluated 140 cystic lesions, and we saw that we increased to 86% accuracy using the new technology.
Yeah.
So
great.
it's incredible. So
Yeah.
I think it's
And
real indication nowadays to use this kind of technology as a complementary.
Yeah. Right. Especially in a case like this when the management is 100% different. I mean, we're talking about no surveillance at all for benign serous cystadenoma compared to potentially a Whipple procedure if this is an IPMN
totally
with main
agree.
duct involvement. So that's a huge, huge treatment difference. Yeah. So we're just getting the confocal set up. I'm pretty happy with my window here.
Yeah, I
I've
think
already
it's very
confirmed I
nice.
have no vessels in my way and I have pretty straight shot.
Perfect. I don't know if Michelle is looking to us. Huh? Where is Michelle? Michelle Cajal. Huh?
All right. Okay. Yeah. So the machine, there's a fiber that goes through the 19 gauge needle, and it's very fragile. So we're just making sure that we're straight and not bent here as we get set up.
Hello. Hola.
Okay.
So we need to preload.
Yep. So it's out.
Wait. Momento. So
So you measure in advance. I don't know if you can see on the camera.
so we are okay here.
Okay. Okay. So our needle is ready. Okay.
Maybe you need to.
Unfortunately, yep. I'm going to have to straighten out just a little bit in order to... All right, 1 second. I'm just going to have to straighten my scope. Okay, maybe there.
Okay, I will help you.
Okay.
Let me see.
So I'm just straightening it out. Sometimes you have to actually straighten your scope. So that should be pretty straight.
Let's see. Yes. Very important to. There is. Perfect.
Okay, all right. So
Now we need to.
so we have to go back into the bulb. Okay. Okay. So let's get our
and
position.
sometimes that's the problem that we lose the position.
Yeah.
But we can see even here.
Here it
We
is.
need just to evaluate if this is an IPMN or not.
Okay, so this is
So-
actually a different area, but I think still. Okay, although I like my.
It's not a bad area.
Yeah.
Maybe the head of the pancreas.
Yeah.
You can also evaluate.
Yeah.
Oh, there.
Yeah.
There is.
Yeah.
So just aspiration.
Yeah. So I'm actually going a little deeper in the duodenum. And just suctioning the air. Air is the enemy of EUS.
Yes.
Okay, so that's a little bit better. Okay, so let's find it.
There
Yeah,
is. There
yeah,
is. You have
yeah.
very nice.
So here I'm pretty happy with this.
So I will
Okay.
put here.
Yeah,
Okay,
so
perfect.
again, I'm just gonna flow.
Perfect.
So no vessels here at all. You can't even see that the flow is on, which is great. Okay, so again, now this is one where gentle pushing out the needle is not gonna work. This is gonna take a quick, sharp jab.
I will go out. plastic here.
Okay.
Okay, now you are
Okay.
over there. You're inside.
Okay. So there you can see that my needle's in the lesion. I'm going to go just a little bit deeper in here. I'm going to take my flow off. Okay.
I think
Okay,
a
I
little
think
bit deeper, huh?
We're pretty good.
Go, because you have still. Go deeper.
Okay. Okay.
Wait.
Yep. Okay.
Okay, now you pass.
Yeah. Yeah.
Okay.
So we want to be somewhat close to the wall here. Okay. Okay. And now
And
you
now
can
the
see the
confocal
probe is
there.
out. Yep.
Okay.
Yep.
Voy a ponerle la fluoresceína. Ya está puesta.
Okay.
And you have your image there.
Yeah. Okay. So we're just gonna rotate a little bit, trying to find some pathognomonic features here. So we're looking for, if this is a serous cystadenoma, we should see a superficial vascular network, which is really pathognomonic for serous cystadenoma. And if it's an IPMN, we should see finger-like papillary projections. Unfortunately.
Maybe if you move like that. Wait.
And sometimes, confocal is very helpful when you find these.
Oh, look.
Oh.
Beautiful. This is an IPMN. Look, the papilla.
Aha. Okay. I was going to say, it can be very helpful. It's perfect when you see what you want to see, but sometimes can be
So
tricky
this
because
is
your
very
sampling size is
typical
so small. But this
of
is
IPMN.
this is pathognomonic.
Pathognomonic of IPMN.
So you see the papillary projections there.
Incredible.
Yeah.
So we have a diagnosis now.
Yeah.
That's why this patient have chronic diarrhea.
Yeah. So again, it's just about sort of twisting and turning, little tiny movements. We've already had our diagnosis, so I don't think we need to spend too.
We will retard the needle.
Okay, so I'm gonna actually come out now.
Yeah, totally. Come out.
Okay. Oh, sorry. Okay. 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 So that was actually very useful and very helpful. And
so
I still think it may be helpful to biopsy the wall. What do you think?
Yes.
Yeah.
Totally. Wait. Okay, retírala esa y precárgame la Murray. So I always use the Murray biopsy forces preloaded because it's better and easier than pass in this position.
Yes.
Moreover in the head of the pancreas. But now we have an optical image from the histology.
Right.
That for us is without an IPMN.
Right. Right. And it's great, the probe is very small, so you're only seeing a small area, and that's why you kind of need to rotate around. But we got a perfect image right there. And what's nice is you can actually go back and slow down the image and look through and freeze so that you can really maximize your viewing.
Yes. So I think this patient needs a surgical resection.
I think they're looking at least a Whipple.
And probably there are some worrisome features that probably we are limited by the EUS evaluation.
Yeah.
And I think that the macroscopy of the complete histology will help us to determine if this is neoplasia inside,
Do your surgical colleagues here, if you tell them it's an IPMN based on the Cellvizio technology, are they comfortable going to Whipple with that? Or?
That's a really nice question.
Yeah.
I think worldwide they don't believe. It's very difficult.
It is.
It's, but that's why that's the reason why I use Murray biopsy also. And when you combine both technology, you increase 36
sensitivity. by a lot. Yeah.
But 3-6 times the possibility to have a good diagnosis. ¿Ya está cargado o
Yeah.
no?
Yeah.
A ver, ¿qué
Yeah,
está
I
aquí?
agree. I find sometimes with the new technology, you need a couple modalities to confirm the diagnosis
Okay.
for when we're talking about doing a major operation. But thank you. Okay. So again, we're passing a 19 gauge needle with our
So
biopsy
the
forceps.
ideally situation is to avoid to go out from inside the cyst, but the risk of to broke the probe is too high, so it's better to
So once
to
again,
go
I'm
out
just
with the needle and to go inside again.
straightening out my scope
No sé
here.
si le pusieron antibióticos. Okay.
I got it.
Okay, it's
Okay.
very important also to put antibiotic prophylaxis previous.
Yes.
So we already do that.
Absolutely.
It's very important for our friends that are looking to our live channel today.
Yes.
our
And
live
I
transmission.
actually sometimes will send them on a couple days of antibiotics, even to go home with. I know that's a little more controversial, but do you give one dose and that's it, or do you send them home on antibiotics?
Yeah.
Okay, so let me find my position again. So the longer the procedure goes, the more insufflation we get, and sometimes can be tricky.
Este paciente lo vamos a despertar en esa sala para que la otra paciente lo ponga acá y avanzar rápido, porque todavía no termina acá. Patrona.
Okay. Okay. So you can see the bowel full of air here. All right, 1 second. Alright, so I'm actually going to pull this catheter just in a little bit.
So,
Okay. Okay. There
I
we
think
go.
you can do it there.
Yeah. Okay.
Don't worry to go
There we
because
go.
it's the same lesion.
Yeah. Okay.
No me aguante, por favor.
Okay.
Milena, déjate conversar.
Alright. So just trying to find a good, perfect window. Again, I always flow. And you can see I have no vessels in my way.
So this is a very interesting case.
Yeah. Thank you.
Wait,
Yeah.
there you are.
Okay.
No, you're a little bit
Yeah,
far.
can we?
Maybe if you
I think.
wait. No.
No, I think I have to come back a little bit. And then get it more here.
Aspiration maybe, and
Yeah.
you can have.
There we go.
There is.
Okay, here it is. Okay, just if you can hold
Okay,
it right
I
there.
can give.
Okay, that will work. Ugh. Okay.
Oh, whoa.
So I'm a little bit through it, but I believe I'm in. There we
I
go.
think you're inside. Huh?
I think so. Yeah. Okay. I just wanted to make
Push-
sure that
push
I was
more?
in a component.
Yes, you are.
Okay.
You are.
Good.
Perfect.
Okay. All right.
Perfect now.
Okay. So now we're gonna put the forceps out. So you can see you want to see it tent against the wall a little bit. So go ahead, open.
Oh, abre.
Yeah.
Okay, so this is very important.
And then you want to push until you see it tent against the wall a little bit. Okay. Okay.
Abre.
Okay, close here.
I believe.
I don't think we got
No.
a good piece there. No.
No.
Okay, so let's
Okay,
open
abre.
open here. Okay, so
Okay,
you're gonna
maybe if you retire your needle a little bit.
push.
Wait. Yes, you will
Yeah.
have more space. Wait.
Yeah. Okay.
Push more. You.
Okay,
Okay,
there we
abre.
go.
And now you need to move.
Is that
Go inside.
locked? Okay. Okay.
Uh,
There
inside
we go.
and out.
Okay, so now I think
Cierra.
we're tending. Try closing here, and you should see.
Yes, you have.
I have it because I feel it.
Yeah, you
Yeah.
feel. Yes,
Yeah.
perfect.
So it's a little bit by sight on EUS, but it's also you could take it. It's also a little bit by feel. You know, you want to see it tenting away, and then when you pull the forceps back, you should have to feel a little bit of a tug.
Yes.
So
So I think one biopsy is okay. Huh?
okay, okay,
So we will close this case.
okay. Do you want to aspirate some fluid as well?
Yeah, if you want. Yeah.
Okay. Okay.
I think will be a little bit difficult.
Yeah.
Let's go to see.
Yeah.
Everything.
We'll do the full
Everything, the
full
full,
trifecta. So I'll just take a syringe with suction.
Okay.
Yeah. Thank
So
you.
we will perform an aspiration now
Yeah. That's probably going to be thick,
So
so it
will be
might take
difficult.
a second.
because it's mucus. It's
Yeah.
not. It's not the same.
Yeah.
So there is a lot of other kind of
But actually,
techniques that has
you
been.
can see the area where I had my
described.
needle in has collapsed.
So you have look.
It's starting to
mucus.
come.
It's very.
It's very thick, very thick. I don't
It's
know if you can
mucus.
see on
We can see. Wait.
the camera.
¿Puedes
Yeah.
mostrarme la cámara, por favor?
And actually, it looks a little bit dirty. Yeah. Or
You
maybe
see?
that's just actually a little blood too.
Ah, it's mucus.
Yeah. But it's very thick. Yeah.
Okay.
Okay, I'm
So-
gonna come out. Okay.
Okay, voy a mostrar en la cámara. So you see here,
It's very thick.
it's very thick.
Yeah.
So this is completely mucus.
Yeah. So everything kind of goes with our diagnosis here. It's
So
nice
I
everything
think,
has lined up properly. And then I would flush the needle.
Pónganlo solo ahí.
I'm sure there's
Sí, it's okay.
there's some material in the needle as well, I
Yes.
think. So yeah. So okay, and I think
Yes, we will close this case.
we can stop
Cerramos este
there.
caso.
Okay.
A este material también mándalo ahí.
Okay. So all
we'll-
right, thank you so
you
much.
need to wait some minutes for the next case.
Okay. So we're gonna take a little break again, and then
Yes.
we'll see you shortly. Okay. 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 He's all section. clearly metastatic to the liver, and then, but even then we like to have a tissue.
We will close because we have problem with the C-arm.
Yeah. Oh, okay.
Yes. So, estamos al aire. So we will close this EUS journey.
Okay.
I think first I would like to say thank you, Amy, for coming. It's really a pleasure to have you.
Thank you so much for having me. It was
expertise.
so much fun being here and doing cases.
Your expertise
so
here
much.
in our unit. So tomorrow we will have some poem cases. We have 8 cases with Michelle. Michelle is coming this evening. He's flying at 11 o'clock. And thank you so much. We have the last case that we will perform off camera. And we will continue working here at the unit. So thank you so much for staying with us. And you are invited tomorrow to assist poem cases. Thank you, Amy, again.
Thank you. Thank you so much for having me.
Okay.
Thank you, everybody.
Bye-bye.